Great. Welcome, everybody, and thank you for joining us today for our private investor meeting with Addimmune. Addimmune is a clinical stage gene and cell therapy company that's made tremendous and groundbreaking progress in developing a functional cure for HIV. The company recently announced a merger agreement for a business combination with 10X Capital Ventures Acquisition Corp., which is a special purpose acquisition corp, and the resulting combined company will be traded on the New York Stock Exchange. The company boasts a world-class management and leadership team, and they're currently raising up to $50 million to expand their HIV research initiatives, as well as expedite the company's journey towards regulatory approval. Thank you guys so much for joining us today. As mentioned earlier, we are recording this so you can share it with your co-investors or review the information again. And without further ado, I'd love to introduce the company's founder and CEO, Jeff Galvin, who is a good friend of ours, and he's a pillar of the Mid-Atlantic biotechnology community. Jeff, welcome, and thank you so much for sharing this awesome investment opportunity.
Thanks, Tien, and thank you to everybody that's attending today. I really appreciate your interest in Addimmune. Addimmune's goal is to create a one-and-done single administration cure for HIV. Now, you could understand how, monumental that could be. If somebody who's been living with HIV and suffering with the short-term and long-term side effects of lifetime antiretrovirals, the way it's treated today, could come in and in one, two visits to the doctor, one for a blood draw and one for a reinfusion, could walk out and never think about HIV again. They could naturally, with their modified immune system, they could naturally suppress the virus at levels where they're not contagious, they can't get AIDS, and as a bonus, they can never get it again. So even if they got an exposure to HIV, they wouldn't be able to recontract HIV. Sounds like, science fiction, but in fact, we feel like we have line of sight and some really fabulous data that says that there's a good probability that we can reach that endpoint. And we have also data from our phase 1 and our analytic treatment interruption that says that even if we were to fall short of this one and done cure, we may have something in our hands that would revolutionize the treatment of HIV, a $35 billion market today, which is predicted to be $40 billion by 2028, that we could do a one and done treatment that would lower the viral load so much that you could greatly reduce the antiretroviral therapy, thus reducing all the side effects. You may not realize what 1.2 million people in America are going through right now, but they're taking daily medication where they're getting nausea, diarrhea, fatigue, headaches, depression. But long-term, it gets really expensive, these side effects. So long-term exposure to antiretroviral agents can turn into liver, kidney, heart disease, and cancer. So the average patient, so somebody who contracts HIV, the expectation over their lifetime in the United States is $1.7 million worth of healthcare. But less than half of that will be the antiretrovirals themselves. The other half will be the consequences of this long-term chronic viremia and the antiretroviral agent side effects themselves. And so this idea of even, reducing antiretrovirals will be hugely enabling, huge improvement in quality of life and huge reduction in the cost of treating these patients. But of course, that one and done cure, that thing that we think, and I got to emphasize think, okay, we've got data that says we're on track. We got some things to prove still, but when you see this data, you'll see why we're so optimistic that we can get all the way through to that goal line, one and done. Come in, and when you leave after that second doctor's visit for a cost that's less than the normal lifetime treatment cost, these folks, for all intents and purposes, consider themselves normal. They never think about HIV again. And just while I'm flipping through the disclaimer slides here, let me mention that the worst part of being HIV positive, I speak to people that have HIV all the time. The worst aspect of living with HIV is the stigma surrounding HIV. And you might think about this yourself for a second. If your waiter came up to you and he said, "I'm gay," you probably wouldn't think much about that. You'd be like, "Yeah, cool, can you get me a glass of water?" But if he came up to you and he said, "Oh, I wanted to let you know I'm HIV positive," that would be scary, because a lot of people don't know how hard it is to transmit HIV. It doesn't matter if your waiter has HIV, you're not going to get it from him. It doesn't matter if the chef back in the kitchen has HIV, you're not going to get it from them. That's, not how HIV spreads. But we all remember the 80s where HIV was a death sentence. And so, this stigma and this association that it has with certain behaviors or preferences or whatever is something that, is a psychological burden on these folks for life. They actually say that that's one of the hardest things about being HIV positive, is that stigma. All right. So I kind of told you this story already. I'm going to whip through this slide, but we're right now we're in the process of attempting to get a public listing. We're working with a company called 10X Capital. And I need to warn you that, this is, you now have information that is all public, but keep in mind that, information that you have about our company could impact your ability to trade that other company that we're merging with until the merger is final. So be careful about that, because it comes with there are some rules around knowing more than the general public, which might apply. So just be cautious there. But anyway, so there's this company out there. It's a SPAC. SPACs in some cases have a bad name because they were overused in 2021 and 2022. A lot of failed SPACs, a lot of companies that probably weren't worth bringing public, a lot of bad results afterwards. But the way that we're using this SPAC is to obtain a listing. You can think of us as just buying that listing at a cheap price. And what we're doing right now is we're raising $50 million, almost like an IPO, but we can raise it before the de-SPAC. So we know the day that we get a listing, we know how much money we have in the bank. So I really like the way that we're going about this. And you can read all the details online. All the documents are filed with the SEC. So you can look up that SPAC and you can find out everything about us. So that's the intent, is to get into the public market, which makes this kind of a unique opportunity because we have some visibility on liquidity. Then we are going to show you some data today that shows that we're launching from an incredible point, that the possibility of, either a functional cure or an adjuvant therapy, a drug, seems very, very good. You can judge this for yourself, but I think the data speaks for itself. And there are articles out there, which we will make sure that you guys get after this presentation, where you can dive all the way down into the details of that data and see why we're so enthusiastic and optimistic about the outcome in this. Now, the market is gargantuan, right? There's 5 million people just in North America and Europe who are living with HIV. I promise you, if you talk to any single one of them, they would sell their house or give their right arm to be cured. So, the demand is out there. I think that one of the important economic drivers of this is that incredible cost in insured countries of $1.7 million means that there is an opportunity to not only grow a big company, but to do that while reducing overall healthcare costs. So I think that's what, is probably the exciting, opportunity here. I'll mention one more thing about the raise that we're doing. Right now, we're doing what's called a 3x liquidation preference convertible note to equity. Okay, it's got a 3-year maturity. And what we're saying is that when you buy into this round, it will be tied to shares at $10.15 a share. And that we're warrantying, or you could say guaranteeing, we're ensuring, it would be the best way to say this, that you'll get no less than 3x in 3 years. And how do we do that? What we're saying is we're going to get public and we're going to turn over the shares to you at the end of 3 years, those shares that you locked in today. and that we're promising that they will be 3 times that $10.15 price. Okay, so 345. That's a 44% IRR plus the required interest on that, IRS required interest. So what happens is, what happens if we don't get to that number? We'll sell off the company. We have a tremendous amount of assets, and we will pay back that 3x liquidation preference, and that is senior on the cap table. So as you're thinking about this, and I think this is important to, professional investors, thinking about your worst case scenario, we have some really good risk mitigation there. So you can get all the details of that, but we are going out there, and I feel very confident that we will return no less than 3x, but at the same time, it's tied to the shares, so your upside is unlimited. Okay, so if we do what we're hoping to do, it could be way better than 3x. Of course, I'm betting that, since I'm one of the people who owns a lot of this company, and obviously I would suffer greatly if we had to sell it off. So how do we do this? How do we take a person that's living with HIV and make them immune to HIV? Well, it turns out that HIV, the only reason it gets in the body is it finds the HIV CD4 positive T cells. These are the ones that are specifically in the body, specific to HIV, that are tasked with surveilling for the HIV pathogen. Now, you have an infinite diversity of CD4 cells in your body. You have some for the flu, the colds, bacteria, fungus, everything, even cancer. They all have specific antigen receptors, so they're all tuned to certain pathogens. And that CD4 cell, when it sees that pathogen, it creates an immune cascade. So the CD4 cell, think of that as the general of the immune army. And HIV has evolved this incredible capability of literally being able to infect that general, kill it off before it can call out the Air Force and the Marines against the pathogen. So HIV disables the immune response against itself. It's the first thing it does when it gets into the body. And it takes a very, very small amount of HIV, successfully finding one of these cells, sets up a viral factory, and these cells are really great at spreading it to each other. And so as a result, within 90 days, zero immune response to HIV. And then HIV can spend 5 to 10 years depleting out other CD4 categories. So you lose, people lose their ability to fight a bacteria or a fungus or something like that, or some other virus. That's when people get AIDS, acquired immune deficiency syndrome. That's what kills people. HIV has never killed somebody. It's the consequences of HIV. So what do we need to do? We need to stop that infection and depletion of the CD4 generals. Okay. Well, if somebody has had all their CD4 HIV specific generals depleted out of their body, and they go on antiretrovirals for 1 to 3 years, they get new ones out of the bone marrow. Because they're on suppressive therapy, these new ones out of the bone marrow don't get infected, so they're just circulating the bloodstream doing nothing. That's when they come into the doctor's office and they get a 300 milliliter blood draw. It goes through an automated cell processing protocol where we go ahead and stimulate it so we can get more of those cells. We stimulate it with peptides that cause these HIV-specific CD4 generals to expand. So we have a slightly higher quantity. Then we deplete out the non-HIV cells, because why waste a lot of expensive reagents on things that don't fight HIV? We want the HIV fighters. Then we go ahead and we modify them with a lentiviral vector. So we use a virus to install genes into those generals that creates kind of a body armor around them. It strips off an entry point from the outside of the cell, and it also puts these protective agents inside called interrupting RNAs that can knock out the HIV genome and prevent it from working in the cell. 3 levels of protection. Now, we know that people that are CCR5 negative are resistant to HIV. So there's a lot of evidence out there from the Berlin patient, the London patient, the Amsterdam patient, New York, the LA patient, that just depleting the CCR5 protects the cells, but we put 2 other protections in there. So this is the broadest protection ever, and it follows along the experiments that you've seen in the past. Once we have these protected cells, we just culture them up to 1 billion cells, we freeze them, test that a product to make sure it's pure, no contaminants, and then it's reinfused. 2 outpatient visits. Okay, this is all outpatient. So they come in for this leukapheresis, and then they come in for an infusion. We think the final product will be about a month, vein to vein. At that point, theoretically, they throw away their meds, their antiretrovirals, never think about HIV again. They can't transmit it, they can't get AIDS, and they can't recontract HIV. All right, I'm going to skip this slide. It just shows you, this is the viral vector, and it shows you the 3 protective things that we put into those cells that protect them. But the idea is once you've protected the general, guess what? He can do his job. If he does his job and he tells the CD8 cells to strike at viral factories, and he tells the B cells to make antibodies that fight this virus hand to hand, it turns out that HIV is a very slow-moving and fragile virus that's easier to clear than a cold. That's the whole theory. It's been shown already to work in the Berlin patient, London patient, and there's even been one gene therapy where all they did was clip CCR5 in enough cells. And there's a guy who's been walking around from a Sangamo gene therapy that hasn't taken his meds in, I think, 10 to 12 years now. So he's immune to, he still has small amounts of HIV in his body. Doesn't matter. He's got an immune system that fights it. Can't get it back. And he doesn't need any medicine to control the virus. So he's living without that antiretrovirals. Now, it's a big difference when you do it this way that we're doing it with a gene therapy versus the way that the London patient or the Berlin patient was cured. They had to get bone marrow transplants from people that were naturally CCR5 negative. Okay, in other words, people that had this natural immunity to HIV. When you transplant their immune system into somebody that has HIV, it controls HIV. That's what they proved with the Berlin patient. But bone marrow transplants can be fatal in about 50% of the cases. And so this is not a cure for HIV, obviously. And there's not enough bone marrow in the world to even cure 1.2 million people in the United States. All right, so we have got data on this already. We did a phase 1 where basically we did the treatment. The FDA agreed to do this all outpatient, which I think is really exciting because we were able to show in the IND with a gene and cell therapy, you don't even get to go into patients. You can't go into humans until you prove theoretically it's going to be safe. Now, why is that? Well, if we take a college student and give them a gene therapy to test out whether it's toxic, it's a permanent change to their body. You can't, it's just unethical to do it to somebody unless they might also benefit from it. And also the FDA raises the bar in the IND to say, you got to really show us that it's highly unlikely to cause problems before we let you test it. So not only did they say, okay, you can do that now, we had shown enough in the IND, but they said, they told us to use what they call healthy patients. In other words, well-controlled people that are considered healthy by the FDA. And they told us we could do it all outpatient with no inpatient days. It was very unusual for cell therapy because if you look at CAR Ts, for instance, they're always done in a hospital. And this is similar to a CAR T. Pull out T cells, modify them, put them back in. But we're not changing the behavior of the T cells. So we believe this is safer than a CAR T. And so far, here's the results. 7 patients treated, 0 serious adverse events. Okay, that's as good as you can do on the safety. And then, since we're actually testing in patients that have HIV, we get a secondary endpoint, which is to show what we call blood markers of efficacy. We studied these cells in the blood for 180 days to make sure they're behaving as we expect them to, and to see if there's any signs that they're working like a normal immune system. And the answer was yes. So first of all, they engrafted, and you can see on this chart on the right-hand side here that they engrafted. They actually expanded initially. That was very interesting. We're not exactly sure why that was, but we also saw them call out to the CD8 cells. So in other words, they didn't just expand, but they actually told the CD8 cells to expand as well. So we saw initial signs of an immune reaction there. And these cells persisted for more than 180 days. Now, you see they go down in quantity. Why is that? Well, if you kept every immune cell that you made during your lifetime, by the time you're 25 years old, you'd be twice your normal weight. Now, why is that? Well, you make a lot of cells to fight a pathogen. But when that pathogen is no longer an issue, your body knows how to naturally reduce those cells so that you just have a small quantity called memory level that can come back if you need it. Well, that's the same thing that happened to these HIV T cells that was expected. We thought they would decline over 180 days, but we wanted to see that the quantities were still sufficient that you could get an immune reaction even up to 180 days. 7 out of 7 passed that as well. And then when we take out the cells and we look at them to see whether they still respond to HIV, they still respond to HIV. So 100% on our secondary objective of blood markers of efficacy. But what do you really want to know at this point? What you want to know is, how does this work against the virus, right? So we went ahead and we created an analytic treatment interruption and invited those 7 patients into that treatment interruption. Now, even though the number of cells was much lower, so we didn't expect this to work all that well, we wanted to see that even a small quantity of cells should be able to expand against the pathogen and show an immune reaction to that pathogen and have some effect on that pathogen, even in small numbers. So we petitioned the IRBs. The IRBs are the safety people for the doctors, and they said it would be safe to take these folks off of their antiretrovirals under the protocol that we offered. And we asked the patients, because it was all voluntary, and 6 out of the 7 agreed to go off their antiretrovirals. So what were the results? Phenomenal. Okay, now I don't expect you to understand this graph, but let me explain something. So pay attention to me for a second instead of looking at these numbers, unless you're an expert. What do you expect to see when you take somebody off their antiretrovirals? Well, a normal person doesn't have any protection against HIV, right? So HIV comes out of the viral reservoir and it starts attacking CD4 cells. That's what it does for a living, right? Well, if it's got no suppressive therapy in there, no antiretrovirals to hold it down, it starts infecting those CD4 cells, and you would see a decline in CD4 cells. This always happens, except for the exceedingly rare cases, 0.1% or less of patients don't see a drop in CD4s almost immediately after taking them off their antiretrovirals. What else do you not see? Well, what you don't see is, because the CD4s, the generals, are being killed off, you don't see them calling to the CD8s. So the CD8s don't bother expanding. So what did we get? You expect to see CD4s go down and CD8s not to react. We got the exact opposite, 6 out of 6 patients. The blue line is CD4s. You see they're relatively stable in all of these patients. As a matter of fact, they react. And when they go down, we think that they may be migrating. We don't know that for sure. But you see how they pop right back up again? And you get a stable CD4. That means the generals are surviving the attack. Now, we need to get more of this. I want to make sure that I disclaim this with 6 patients is a small sample, and our next study will have 24 patients. We're going to get statistical power behind this, but this is incredibly encouraging. 6 for 6, stable CD4s, and then look at these CD8s. As the virus comes up, the CD8s react to it as well. Now, the virus doesn't get suppressed all that well. Why is that? Well, these cells have been sitting around for, 6 months or more in the body. And so, it's like any naive T cell. So, when you get the flu, what happens with the flu? The virus goes up so fast, and the immune system takes a little while to catch up with it, right? Same thing happens with HIV. So in this case, they went up to pretty high viral loads. So we put them back on antiretrovirals, and we brought them back down to what's called well-controlled, undetectable. But we did get to see that the immune reaction was what we were hoping for, was that the CD4s would hold out against the attack and the CD8s would start reacting. This is a normal, or let's say an effective immune response to a viral pathogen. This is incredibly unusual, and we saw it in 6 for 6 patients, but I'm not done yet. Okay, so what happens when you get the flu, right? Your immune system catches up with it and you expel the flu, and then your immune system comes back down again. Your body normalizes the number of cells and you feel all normal, and you have a small memory level of them there still, that if the flu comes back, if that same flu comes back, you're a little bit more prepared, and those things will stay in an activated state for about 6 months. Well, why is that? Well, when your body sees a virus or something that looks like a virus, it will activate the T cell subset that's appropriate for it, and put them in effector state so they can react much more quickly. That's called a vaccine, right? If you get a COVID vaccine, you still get COVID, you just get no symptoms because the virus can't even get off the launch pad before the immune system reacts to it, caps it at such a low level that you never even feel it. You're probably never even contagious. But the reality is you still catch it, COVID. Same thing's true about the flu. You get a flu shot, you get the flu, but your body has been alerted to what the flu looks like, and it's ready. And therefore, it gets ahead of it so fast that it's able to suppress that virus so effectively you get no symptoms. Okay, what's the first exposure to HIV look like? Looks like a vaccine. And since we're able to just put them back on suppressive therapy as the virus went up, they never even felt it. And we don't believe it caused any damage to their body, even though we let the virus go up temporarily. But now these naive cells have seen the virus. So what did we expect next? We thought, if we withdraw them a second time, these cells should react way better if they're working properly, right? If this is creating an effective immune response. All right, so what happened? We invited these 6 patients to go off their antiretrovirals a second time. 4 agreed to it. 4 out of 4, multi-log reduction of viremia in the second withdrawal. There's some really interesting stuff in these graphs, and it's all in an article we can send to you, and you can give it to your experts. But here's what's so exciting. Look at this patient right here. Let's see. This one's a perfect example. It's pretty readable. So patient number 8, he zoomed up to almost 600,000 particles per ml, which is high for HIV, but it's pretty low in terms of viruses. Did you know that by the time you cap the flu, if you get the flu and you get symptoms of the flu, you're at 50 million particles per ml. This guy got up to 600,000 particles per ml of HIV, which is way too high. We immediately put him back on antiretrovirals. But look at this. The CD4s came up and the CD8s came up, but they came up after the virus. That's what you expect with naive T cells. Now let's look at the second withdrawal. So we brought him back down to what this is called well-controlled. Now, what's interesting, you see that the virus is on this log scale on the right. Each one of these numbers is a factor of 10. So, this is basically 10. That's 100, 1,000, 10,000, okay, 100,000 millions, okay? So this was just under 1 million. So we bring them back down to probably 20 particles, 30 particles per ml. And then we withdrew them a second time. Look at this. As the virus comes up, these cells react actually almost ahead of it, it looks like. They were detecting such small amounts of the virus and reacting to it. It was just like a vaccine. Another thing which is incredibly encouraging, that this immune system is working properly. All right. Now, it's on a very small number of cells because we waited so long. We infused them with 1 billion cells, but we waited 6 months before we did the first withdrawal, actually sometimes up to 1.5 years. And the second withdrawal, is doing quite a bit better. But what if we were to do their first withdrawal, a short withdrawal to alert the cells right after we infuse 1 billion of these, and then we do a second withdrawal right after that? We'd expect to see much better than this. But we saw something that was incredible. Look at the peak here. Peak here was about 14,000 particles versus 600,000 particles. Doesn't look like much on this graph, but if we drew the graph with an absolute scale over here, what you'd see is this would look flat, totally flat down here. This is a huge, huge difference in the viremia. This is why we got excited also that this could be an adjuvant treatment if it turns out that these lines are durable. Now, let me just show you the next graph here. These are the first withdrawals, and these are the second withdrawals. Look at this. That looks pretty stable for pretty long. Now, if we can prove that that's stable for a lifetime, and if these immune cells are seeing any virus, they will stay in the body forever. Did you know that CD4 cells can clone themselves in the lymph nodes or even in the bloodstream under stimulation? Okay, and they will continue to alert CD8s. Okay, so if this is durable, and we've lowered the virus by multiple logs, we could reduce antiretrovirals. If we reduce antiretrovirals, we reduce the side effects. If we reduce the side effects, we reduce the cost, and we reduce the discomfort. So this could be hugely enabling to everyone that's taking HIV meds now. We could make their life better, and we could make their life cheaper for the payer, okay? That's our theory, is if we can prove that this thing can become a drug, that's an adjuvant drug, even if we can't get all the way to cure, this is incredibly valuable. And that's what we're looking at here, is we believe we've already shown improved therapeutic response. All right. Improved therapeutic response, if we can show that it's durable, means that we can make longer acting antiretrovirals. There's a 2-month antiretroviral right now. Once every 2 months, people can get a shot. It's called Cabenuva, but it's possible that a 6-month shot could be made. As a matter of fact, Gilead's working on a once every 6-month pill. All right. But they need to lower the viral loads down reliably in order for the smaller amount of antiretroviral or Gilead's molecule to get it the rest of the way to non-contagious. So we could be critical in that. 2 out of 4 of these patients achieved a level that is consistent with what's called a long-term non-progressor. And why is that significant? It's significant because that's very rare that people are long-term non-suppressors, less than 0.5%. And we got 2 out of 4 that got to that level. All right. We still need to show that it's durable, but long-term non-progressors don't need antiretrovirals to prevent AIDS. They're actually suppressing the virus well enough that they don't need to take ART medication to prevent depletion of their immune system. They're still contagious though, so that's not the goal, right? But if we got everybody to long-term non-progressor, it might be a tiny bit of ART that they take every day. This doesn't affect them at all in terms of nausea, diarrhea, fatigue, any of that stuff. And, they could have the benefit of being non-contagious. Non-transmissible is a level of about 200 particles per ml. If we redo this experiment now, which is what our plan is, but we take them off their antiretrovirals immediately after infusing 1 billion cells, instead of waiting until that is way, way down. The number of cells is tiny compared to that 1 billion cells after 6 months or a year and a half. But if we did it right away, we might get this suppression level down to non-transmissible, or even what we want to get is what's called durably undetectable. If somebody takes meds every single day, they are undetectable. And if they're undetectable, they're non-transmittable as well, which means that they are clearly safe and they cannot transmit the disease. The market is gargantuan, 5 million people, but let's look at the ones where it's an acute need. 5 million people in North America and Europe alone that are insured, that could afford this treatment. 3.8% of them, actually, antiretrovirals don't work for them. That's 45,000 people in the United States. If they don't get a better treatment, okay, and our treatment mixed with antiretrovirals might fix it for them, they're going to suffer and die. 45,000 people in the United States are actually suffering from AIDS symptoms and suffering from such severe side effects of the ART that they have no life. Well, that may be one of the reasons that the FDA was, willing to do this experiment. There are people out there that are really in acute need. But there's another group of people, 7.6% of the people, that don't take their antiretrovirals for hard to address societal reasons, like they have schizophrenia or bipolar or manic depressive or, something like that. And so they're not taking any of their antiretrovirals and they're contagious. And then 20% of them are non-inherent every once in a while, and they are contributing to 35,000 to 40,000 new cases per year of HIV. Now, multiply that times the $1.7 million per patient. They're creating a $60 billion problem per year. Now, that's a problem that lasts over decades, right? So it's not might be $2 billion a year, but when you lay that on every year, eventually you're making $60 billion healthcare for the United States just from that. Everybody says they want longer acting. All right, that's obvious. Gilead and ViiV are the big treatment companies. Both of them are competing for that market of longer lasting, and we might have a strategic asset that we could partner with them. We haven't had any serious discussions about this data with them yet, but we've had a lot of discussions prior, And clearly they're interested if we can show clinical data that would be of strategic interest to them. Now, this I think is really interesting because they're just competing against each other for longer lasting antiretrovirals with less side effects. And as a matter of fact, Gilead has this molecule where they use what are called broadly neutralizing antibodies in their clinical trials to bring down the viremia. This is a very difficult way to bring down viremia, but they're doing it because they want to prove that lenacapavir can get it the rest of the way. Well, what if we were that really easy way to permanently bring down that viremia, and then lenacapavir was a once every 6-month pill? Obviously, that would be a great competitive advantage for Gilead over ViiV. Meanwhile, we could enable ViiV to do longer lasting antiretrovirals competitive against Gilead. We are in the lead 3 to 5 years ahead of anybody else, in our humble opinions. But competitively, we don't see anything close to our project. Even though there are some people that are doing phase 1As, they haven't shown any efficacy yet. And we've shown a tremendous amount of efficacy. You can read about it in published articles. We're not resting on our laurels because we think we have a cure. We do believe that in this next experiment, if we redo this same experiment with 24 patients and take them off their antiretrovirals right away, we should be able to get to functional cure. All right, so that's what we're going to do. We're going to take that into a phase 1B. And so that will be the 24 patients. And our hope is that we'll get statistical data that will power endpoints for a pivotal phase 2 study. All right. But we also have an enhancement to that, 3 different projects on the bench that will enhance the efficacy and potency of this AGT-103T. So we can add those things if we need to drive the potency up or drive the cost down. We also have an opportunity here for a vaccine because our technology could enable vaccines to work. 250 vaccine studies out there that haven't worked. We could change that. The plan is we're going to use this $50 million to power the phase 1B study. We'll have a readout and enough money to get out through that readout in the middle of 2025. That should be another valuation inflection point. We're hoping to go public in the middle of 2024. So there'll be liquidity along the way with a lot of other exciting news that I hope will make this a good public stock. We have an amazing track record of accomplishments in the past. All of you can have this so you can read it in more detail, but there's been a constant stepping forward in success on this project that gives us additional confidence that we can continue to deliver on our milestones. This is a completely reproducible process. That automated process uses standard components, yet it has 5 patents that make sure that we own this lock, stock, and barrel. Okay, so even though we're using standard off-the-shelf components, plus 1 lentiviral vector that is proprietary, that all of these things can be manufactured at a growing set of CMOs. And what that means is that we can rely on those CMOs. We don't have to have our own manufacturing, which is really expensive, as long as we want to. All right, and it's getting more and more competitive. They're driving down the cost and they're driving up the quality. So this is a really good situation that we're in there. Final slide here. Everybody knows it's all about the team. We have a tremendous inside team with unbelievable experience in exactly the right places. So Jeff Boyle, 20 years of clearing drugs and medical devices through the FDA. We poached him from a company that you might have heard of, Addimmune. He was the president there, but he's got a PhD in immunology. I met him through the Maryland Tech Council, and I intrigued him with coming back to the science. He looked at our data, he got all excited, he joined the company as our CSO, perfect guy to get this all the way through the FDA. He's flanked by a guy named Marcus Conne. If anybody in here knows HIV, they know it, Marcus Conne, because he was on the front lines of the AIDS epidemic in the 80s in San Francisco. He treated 3,000 patients. He was one of the few doctors who detected this virus early and treated patients. And then he was involved in the 90s in the first effective treatment, doing thousands of clinical trials. And I talked him into coming out of retirement because he looked at the data and he said, this could work. And he's now the CMO of our company, and you couldn't do better for a chief medical officer. Nick Tressler joined our company several months ago in order to move us forward into this public transaction. A tremendous history of public and private companies. And Karen McCord, my chief of staff. I also have a chief business officer. We have a full staff. Grant is on the call, VP of marketing. We're ready to go. But one of the most exciting things to me is who the jockeys that this horse has attracted. Tommy Thompson, you probably know him as a four-term governor, 16 years of Wisconsin, and former Secretary of Health and Human Services under George W. Bush, running all healthcare for the United States. He could have any board position. He's chairman of our board. Bob Redfield, he worked with Tommy Thompson on PEPFAR. These guys have both been in HIV for decades. Bob Redfield has been a consultant on this for 10 years. First call when he retired out of the CDC was to me to get back on our advisory panel. That's really exciting too. And then these doctors are the who's who of treatment. This is just a small sample of our KOLs and other jockeys that I think are really credible that are picking this horse. All right. I hope you will find something exciting in this. Downside risk mitigation with the 3X liquidation preference. Upside, who knows, right? 5 million people that would give their right arm to be cured. And, figuratively, I don't want to overemphasize that point, but if you get out there and you talk to people that have HIV, the desperation is palpable. They really want to be cured. It's a big difference to be normal. They want to be out of the closet. They don't want to have a secret that they can't talk about with their friends, family, colleagues, strangers, whatever. They want to be normal. And there's a possibility that we could do that. But in any case, we have fallbacks where we could really improve their lives. This is, we feel, a step towards ending the HIV epidemic and maybe putting HIV in the rearview mirror. Thank you.
Awesome. Thank you so much, Jeff. We'll get into Q&A. We have quite a few questions in the chat. The first is it already trading on the NASDAQ or will it be?
It will be. So we have what's called a business combination agreement with 10X Capital SPAC 3. You can look them up. The symbol is VCXB. You have to be very careful about the VCXB. I would caution everybody against trading in that stock until the merge, okay? Because it's just one of these flags that the SEC looks for insider trading. They're going to assume anybody that's buying that has inside information right now, and so you have to be a little cautious about that. But so we will expect to merge with them. The ticker symbol will be HIV. That's already reserved. And we think it will happen in the first half of 2024. And everything seems on track so far.
Okay, great. Thank you. This is from a previous part of your presentation, but someone would like to know, can you discuss when you're talking about the assets, what type of assets and who will be potential buyers of these assets?
So we have a portfolio of patents which has been valued above $3 billion by credible sources. Okay, so that's what we would sell if we had to liquidate the company. We would be selling the data plus the patents. Now, from an accounting standpoint, we also valued those patents from a pure accounting standpoint. This is by EY at $700 million. So, it has to come down by 80% before we can't pay off the 3X of this $50 million raise. Okay. So, would the IP depreciate if we failed? Yeah, sure, it could. Would it depreciate that much? We feel that's highly unlikely, because if you look at failed gene and cell therapy companies, their IP is being bought by other companies and it's being utilized, because the thing about patents in gene and cell therapy is they're reusable in other things. They're like components, like a transistor, a resistor, a rheostat, right? If you had the patent to the transistor and your company went out of business, okay, RCA would buy the patent, maybe at a discounted price, That's what's going on in gene and cell therapy right now. So the patents are still valuable. We think we can cover that.
Okay, great. What is the time frame expectation for the drug to enter the market?
Selling this retail, I don't think could happen before 2028. It's conceivable it could take less time or longer, but the company could have a lot of value in the meantime. As you know, that, you know, biotech companies are valued based on sort of their, in a lot of cases, risk-adjusted net present value on where it looks like they're going. And so, you know, if we keep on posting really good milestones, we think that we're coming out at something that is reasonable, and we can go up as we achieve more milestones, even though we don't have revenue. Now, remember, another thing that is a big signal is we can go out to some of these pharma companies and see if they might be willing to partner with us. We don't have anything on that front to announce today, but you could see that maybe some of this data could attract a pharma partner. And of course, that would enhance the stock value even without revenue. And it would also put a lot of, you know, probably non-dilutive capital in the bank, or maybe, you know, get us another big shareholder, right? So there's a lot of ways, you know, that this thing goes up in value. Doesn't have to be drug revenue, but I think that, you know, the way we look at it is, if we get this data in 2025 and it looks the way, you know, let's say it's the best we could hope for, where we're getting functional cure for a statistical sample, then we would go to the FDA and they would probably, you know, be willing to discuss endpoints on a BLA. So it could be, you know, a year to, it could be like 2 years after that the drug comes out.
Okay, and just a follow-up to that, does the 2028 timeframe include expedited approval potential?
No, I haven't figured that in, because we just don't know how, you know, where the FDA hasn't given us any input on our eligibility for that, but we will apply for every possible expedited application with them. And I think, you know, when you look at the level of suffering in that 3.8%, they might look at that as an orphan disease even. We'll see.
Okay. Are there similar gene therapies known to work in a like manner for other viruses?
Well, most viruses don't need a gene therapy for them to be cured, right? Because they're not integrating viruses like HIV. They haven't evolved to the level of HIV. HIV is just such a clever virus. It's evaded vaccines, right? It's evaded traditional ways of mitigating the virus. So it requires a gene and cell therapy. The thing that you'd have to rely on in terms of having some confidence in our ability to get there is the fact that Sangamo got one person there, and we have a much more efficient and actually a broader protection than Sangamo. They were using a clipping technology. We're using an add gene technology. But the bottom line is since you have two alleles, and when you do clipping, you have to get both alleles in each cell. Very tricky to do. If you add a gene, you can actually put a knockout that gets both alleles. So there's a big efficiency benefit. So we're standing on the shoulder of giants. The Berlin patient and the Sangamo study. The Berlin patient says that people can control their own virus with enough CD4 cells surviving. They can do it. And the Sangamo patient says, hey, this can be done without a bone marrow transplant. So the arc of the HIV cure story is good. We're on that.
Okay. And it looks like we have a question from a hand raised. So Kevin, if you'd like to unmute yourself and ask your question.
One second, sorry about that. I have actually two questions. So for what I heard, Jeff, you guys are pre-revenue, obviously. You're in trials and working on trials and expanding the trials and going from 4 to 24 and etc. So the trajectory for that means that there's a lot of work ahead, right? So we're in 2023 right now. You're expecting to get to market around 2028. And then my question for you would be is, okay, so from a revenue trajectory perspective, I'm not going to ask you to give me any forecast, obviously. That doesn't make even any sense. But what is your plan from that perspective? Because you also mentioned in the same fellow swoop that there are other companies like Weave that you're competing with and might be able to even potentially collaborate because there is some synergy over there. So be interested to get your perspective on both those things.
Well, everything's on the table. Our plan is to do it on our own. If we don't find a pharma partner, we have a very efficient company. We're, burning at about $1 million a month. So this is remarkable for a company that's progressing. We've gotten all the way through a phase 1 and an analytic treatment interruption at a fraction of the cost of most drug development. And gene and cell therapy is part of the reason. You can gain efficiencies there if you know how to use it. And that's a full day lecture for you. Okay, so we can get the money that we need to continue this and to get through the result where it's like Steve Jobs said, they'll know what they want when I show it to them. Okay, and that's the point, is you need to show data in order to motivate either partnering or the FDA or the public. So I think that, all signs, when I look over the horizon, it looks really good. I don't think we're going to run out of money. The 50 million gets us up through the middle of 2025. And it gets us, to the next results, an inflection point, but we'll do additional fundraising along the way. We're going to have to see how the people react to the stock. Look at other gene and cell therapy stocks, okay? And look at how they did. And you'll see that, all of them are pre-revenue, but some of them have significant market caps. And compare their TAMs to us as well. I mean, I think one thing to look at is like, there are companies out there with like a monogenic disease with a $3 billion market cap, with phase 1 results in a monogenic disease, no revenue, nothing.
Got it. Just quickly, Jeff, you mentioned that you expect to use the $50 million. It sounded like to get to 2025.
Mm-hmm.
So 2025 comes, and are you going to then go out to the market again and try and raise more money?
Yeah, I don't think I'm going to wait till 2025. I think we're going to, do pipes, over the first 12 months, and then we may do secondary offerings. I mean, if you look, a great example of raising money, not that they did it, they raised money the best way. They didn't develop their drugs the best way, but look at Bluebird when you get a chance. What you do, and you're a gene and cell therapy company or a biotech in general, you raise money anytime people are excited about your stock. You put a little bit more stock out there and you bring in some more money. Now, Bluebird raised billions. We're never going to need that kind of money. Okay. But that's the way that biotechs go, because it is a long process. And what you need to show is that you're getting closer and closer, so people have more and more confidence, and the stock may react to that. But, I can't promise what the future is, but I'm feeling confident that we will fund it. And I think the future is up. And the 3X liquidation preference is there, whether the stock goes up or not. And then you just look at, okay, what's the, look up our patents on Google. You just go, what are the patents worth? Okay, they're worth a lot.
Got it.
See insurance. Yeah, you're welcome.
Perfect. Our next question is, what was AGT's original mission? And if it wasn't HIV, when did you start to focus on HIV?
The original mission was to make a platform of gene and cell therapy components that you can mix and match in order to bring efficiency to the development of a wide variety of drugs. Sort of like making an iOS or an iPhone, so that we could make drug apps much more quickly and efficiently, because gene and cell therapy has so many commonalities in all these different drugs. We were successful at that. So we're going to take that platform and leave that as a separate company. But what happened was our first experiment on that worked really, really well. Who'd have known that, we spent probably $10 to $20 million developing this HIV drug, which is nothing for a phase 1. But because of this component architecture, because of this efficiency that we brought, we feel that drove down the cost to, 90% less. So with HIV getting this tremendous, data, we thought, okay, the market understands drugs. Remember, you're going to be investing next to institutional investors that are biotech focused eventually, right? Well, they understand the value of a drug and how to value that. They don't understand how to value a gene and cell therapy platform. That is unique and new. So that's why we split. The mission of AGT, it's going to go off as a separate company, and Addimmune is the spin out that will retain the HIV drug. And we think that that's a powerful public company.
Got it. Okay. Understanding that AGT 103 affects CD4s, is there any effect on HIV itself?
No, well, yes, but it's not directly from the cells that we're doing. What happens is if the CD4s are working, then they signal CD8s. CD8s are what are called killer T cells or cytotoxic T cells. And once they're programmed with information about the pathogen, they can actually spot viral factories. Okay, so cells that are infected with HIV, they can actually read the proteins on the surface of the cells. Even if they're not producing virus, they can still see those proteins inside the cells and kill the cells. So those wipe out viral factories. So what it does is it reduces the amount of virus that's being created in the body by reducing the viral reservoir and by preventing new viral factories from being created. So yes, it changes HIV. We don't know, we don't have data on that yet, but in the next experiment, we're going to be measuring viral reservoir as well and inflammatory markers. So yes, we believe it will definitely change HIV in the body, but it's the immune system doing the work. All we're doing is making the immune system immune to HIV. Now it can just work like a normal immune system. That's been proven to be good enough to control HIV and maybe even eliminate it.
Okay. Based on your deeper knowledge, what are the possible short-term or long-term adverse effects that could be showstoppers, and how likely do you anticipate them to occur as you expand the trials?
Well, my opinion, and I'm not a PhD or a virologist, I'm just a guy who's been running a gene and cell therapy company for 15 years. So I have a street knowledge of all of these things. We didn't believe that there would be any adverse events when we started this clinical trial. Now, why is that? It's because we're not changing the behavior of these T cells. All we're doing is protecting them against HIV entry. It's very similar to how antiretrovirals work. The only difference between antiretrovirals is it's a chemical thing that bathes all the cells in your body in that same chemical. That's why it has side effects, right? You take a pill every day. It's like anything. You take an aspirin every day, an Advil every day, you might eventually build up some side effects to it. But what it's doing is it's blocking HIV entry. And as a result, it's suppressing the virus. Well, what we're doing is we're making a permanent change to that immune system so that HIV can't get where it needs to get in order to deplete that immune system. And we're making it work. So we're making people like the Berlin patient. There's a lot of data that he didn't get sick from that bone marrow transplant, and we're not even doing a bone marrow transplant. There's a lot of evidence that that guy from the Sangamo study and all the people that were treated in the Sangamo study didn't have long-term serious adverse events. So I think the likelihood is low. We're always looking for what are called cytokine release syndrome, because if you get enough activity in the immune system, it releases a lot of cytokines, and that can make somebody sick. We see that in things like CAR Ts, okay? But CAR Ts change the behavior of T cells, and they start attacking B cells, and you get a gargantuan reaction because there are so many B cells in the body. But HIV is at a very low level, so we don't believe that the attack would ever get to a level where we get a CRS. But of course, in the clinical studies, we put things in the protocol to protect people against that in case it happens. But even the FDA, looking at our data from our preclinical work, let us do this outpatient. That's really different than CAR T. There was never a CAR T that wasn't done in a hospital.
Okay. Why do you need to merge before you go to market with the therapy? And how does this help your investors exit with a favorable ROI as the company is pre-revenue?
Well, the valuation on, at the offering will be a great return to everybody that, got into this stock before we went public. Now, we don't know what the stock will do after that because it could go up or down. That's going to depend on market conditions. But it is on the trajectory of the increase in this value all along. But it gives us access to the public markets and big check writers that need to have liquidity in order to write a $10 million check or a $50 million check. So it gives us access to all different types of new money. What my hope is, and I cannot guarantee this, but we're ensuring it for the offering we're making to you guys, the 3x liquidity, all right? But my hope is everybody's going to achieve better than 3x, because we'll post milestones and we'll bring in money from professional investors, and we may get some other signal in there that starts giving people return who invest on day one of the public offering, right? There will be ups and downs. Sometimes biotech is in, sometimes it's out. But gene and cell therapy is sort of like the best part of biotech, and biotech sometimes is, gets pretty exciting. So, and we're coming in right now at a fairly low ebb in biotech. And so, that also in my mind, what goes up comes down, right? But what goes down comes up too. All right. If you're a professional stock buyer, in the public market, you see that as well. I think we've got a good story and good trajectory. So I'm very hopeful about the returns, and the reason for going public is access to a lot more money. And if we had 100 million in the bank, we would go ahead and we would broaden our pipeline substantially and get additional legs to stand on.
Okay. Next question is, in terms of total capital needed, what is expected cash burn through 2028?
We think a couple hundred, don't quote me on this because, and I shouldn't even make projections. Let me tell you this, the cash burn is likely to go up from what it is today as we grow the company. And as it becomes more clear that we have a drug, that it's definitely going to market, right? Money gets cheap, and we have a more definitive way to deploy it, to dot the I's and cross the T's and get through that last bit. But I would say, okay, so this, just pulling numbers like right off the top of my head, I can't imagine that we would need much more than a couple $100 million through the end of this project. But there's a lot of different trajectories, and I'm not giving you a projection here, that where we would spend more money because we had more opportunity. And if it was happening slower, we would spend less money because we'd have to, tune for that. This company has survived 15 years on about $80 million. And we have a successful phase 1 in a gargantuan market. Okay. So you can see we have the ability to run lean and mean. We're not going to lose that because we're a public company. There will be some added expenses of being a public company, but we're going to still do that. We're going to stretch our money any way that we need to. So I don't think you have to worry about, I think if you're getting in now, your worries shouldn't necessarily be about the next investors. They're not going to get your 3x liquidation preference. You're still senior on the cap table. You don't have enough of the stock that they're going to worry about it. It's going to be less than 5% of the company probably with this 50 million sale. So, or less than 10% for sure. So, you don't really have to, think any further than, okay, what's normal in the biotech world?
Okay. And I know that we're a little bit over time, so I apologize to everyone for that, but we are happy to stay on and go through the last of the questions that we have here. So our next question is, how much cash is in the SPAC? Well,
we're not counting on any cash in the SPAC because we're really just using them as a cheap way to the market. They do have $22 million left in the SPAC after 2 redemptions. So a lot of the people that were what are called structured players have exited. I can't tell you what will come in from the SPAC, but what I can tell you is the BCA defines our cash position before going public so that we know that we have enough money in the bank to do, to survive as a public company. So the SPAC is 22 million today. We're not counting on a dollar of that coming in. We're raising all the money pre-listing to make sure we're ready to go on day one and start working to drive that stock price up.
Got it. Okay. And I know, Jeff, you've got to run off to another meeting, and
I actually, my meeting got delayed, so feel free to
Okay.
go as long as you want to. I'll hang out.
Okay.
Yeah,
Okay, perfect. Then we'll just go through the last of the questions that you have here if you have that time.
sure.
Have you gotten pushback on the 3 times liquidation preference?
Pushback, in what way?
I think, James, if you're still on the call, feel free to unmute and
I mean,
kind
there's
of-
been people in Wall Street, they're like, it sounds too good to be true, but it's true. You know, you do have to do some due diligence to look at this and go, well, what would this company liquidate at if it failed with the data that it has today? Because there's something of non-zero value in the patents and the data, and it's, you know, up to you to evaluate that. So this is a really great deal. We are trying to take all the risk away from these initial investors so that it makes it easier in a market where people are really nervous about risk. We're trying to take as much of the risk as possible. That's the only pushback we've ever gotten on this. I think some of our own investors have been like, wait a minute, you know, why are these new people getting such a good deal? And what we're saying to them is like, if you like the deal, you can buy it too. All right. So, you know, I think the 3x liquidation preference, it's pretty, you know, it's pretty attractive. I think that sometimes the issue is that people are like, well, wait a minute, like, what's the catch? You know, I don't know of any catch. We're trying to just give you a really good risk mitigation, and that's it. But, you know, we're prepared to answer questions. The S4 is filed already. You can read the S4 on this thing. The BCA is out there. The deal documents for this are out there. You know, evaluate it. We're sincere in our desire to have you join us on this mission, and not have to be constantly an expert on and evaluating every single day this mission.
Can this platform be used to address long COVID sufferers that presumably have virus reservoirs in biofilm?
Yeah, that's possible, but we don't have we're not doing anything on that right now. But this immunoregulatory approach to viruses, we believe, has a lot of further application, okay? Because there's a lot of chronic viral infections that can cause problems like hepatitis B that have not yet been cured, but an immunoregulatory approach could work. That has some parallels with HIV. HTLV, 20 million people in the Far East have that. We think that might be something that could come off this platform as well. Human papillomavirus. Some viruses give people increased chances of cancer over the long term. They're incurable right now, even though the human papillomavirus, there's a vaccine for it. So if people don't have it, they can take a vaccine. But once they have it, okay, they run a higher risk of a bunch of different cancers. We may be able to change that.
Okay. Can you please reiterate what the pre and post valuation of this $50 million raise, or is it a discount to the IPO? If so, how much is the discount?
It's at the IPO, okay, and so the last round that we did was that was a 644 million pre-money valuation of the company. Then we split it into two companies. The platform went one way, and the HIV development is in Addimmune, and Addimmune has a $500 million day one valuation. So 50 million on that would be 10%, but there's other dilution from the SPAC coming in as well. And there are $300 million worth of earnouts if we hit certain stock price targets and milestones in the clinical path. So, but you know, you get the benefit of all those things as well because you're registered shareholders. So, you know, whoever owns the shares on day one, you know, rides the whole journey there. And the stock targets are $15, $17.50, and $20. The initial stock price is set by the SPAC, $10.15. Okay, so you can see our aspiration is to drive this thing up, and the clinical goals we think are pretty good. You know, are achievable as well. We get 5 years to achieve those goals.
Okay, perfect. The next question I think we kind of addressed, but someone was wondering about due diligence materials, and I forwarded them to Mr. Wells, the head of business development. Is that a good place to go to?
That is, yeah. So
okay, perfect.
yeah,
Barry Wells.
Wells.
Emails in the chat.
Yeah, it has everything. You definitely want to request the 3 articles that are out there and this presentation. And then go to our websites. Tremendous amount of information on the AGT website and on addimmune.com. We're redoing addimmune.com for, to do the deep dive on HIV. So it'll be your best source of information going forward.
Okay, perfect. And our very last question is, who holds the IP?
We do 100% of it. This is also a unique thing about AGT and Addimmune. All of our IP was developed internally. We didn't license any of it. This is not a university spin-out project. You as shareholders, okay, and along with the rest of the shareholders, own 26 very important patents. Well, actually, there's 17 that are going with Addimmune, but there is a big patent portfolio that we own 100% with there's no encumbrances on it.
Okay, sounds good. Oh, but a follow-up to that, does AGT or Addimmune hold the IP?
The IP is being split between the two companies, and in the you can see the exact split in the S4. So everything is out in the public domain where you can look at exactly which patents are going which way. But the valuation of the Addimmune portion of that on an accounting basis by Ernst & Young was 700 million plus. Okay. And that should be a conservative valuation. We got much higher numbers from IP experts in terms of its current value. So we think there's enough in there to ensure this 3x liquidation preference.
Okay, wonderful. So that was the last of our questions, and I just want to let everyone know that I put that email in the chat one more time. So if you want due diligence materials or access to those articles, please email him. And also this recording will be sent out to everyone, as well as the deck for you guys to look over. So we'll also introduce you to the AGT team so you can be in contact with them. But we want to thank everyone for joining today. Thank Jeff and Grant and the AGT team. And with that, we can end the meeting.
Thank you, everyone.